Hey, future nurses, quick question. Do you get confused when you hear DKA, SIDH, Addison's disease, Cushing syndrome? Yeah, me too. That's why today we're going to do a rapid 20-minute endocrine review, eating wholly the high-yield stuff you need to know for NCLEX and if you're taking Kaplan. Yeah, for Kaplan too. I literally just did my Kaplan practice, and while I did well, I was kind of shocked that there was a lot I still need to know. So I'm going to teach you exactly what shows up over and over again. No fluff, no long explanation, just the must know fact that will save you an exam day. I'm talking mnemonics, quick recognition patterns, and what they love to test on. Now, in the next 25 minutes, we're going to be talking about diabetes, touching on DKA versus HHS versus hypoglycemia, thyroid disorder, Hypo versus Hyper, adrenal problems, Addison versus Cushing, Pituitary, SIADH versus DI, and Parathyroid quickies. Don't worry, we'll go over them and I'll explain all of these abbreviations. So if you're studying endocrine right now, taking Kaplan soon, or preparing for NCLEX, stay with me. Let's make this stick. Hit that like button, hit the subscribe button, grab your coffee, grab your herbal tea, and let's go. Okay, diabetes. That's like 30% of endocrine questions, so we're focusing on what kills patients fast. DKA, diabetes ketoacidosis, who gets it? Type 1 diabetes, they have no insulin, their body burns fat, which releases ketones, which causes acidosis. Classic presentation, you need to memorize this. The P3, polyuria, polydipsia, polyphagia. Cushing respiration, that's the deep, rapid, trying to blow off CO2. Fruity breath, acetone smell, abdominal pain, nausea and vomiting, blood glucose above 250. It's usually 300 to 800, but I've seen someone with DKA of 1,000 blood glucose. Yes. Labs, you will see their pH is going to be less than 7.5 to less than 7.3 because they are in acidosis. You're going to see positive ketone in urine. You're going to see high potassium initially, then you'll see low after treatment. They are currently, if you're going to do pH, they're currently metabolic acidosis. Treatment. This is tested constantly. We have IV fluids. You want to give them IV fluids first. That's NS bolus because they are really dehydrated. You want to give them regular insulin drip, only regular IV. You want to monitor potassium because insulin draws potassium into the cells, which causes dangerous hypokalemia. You want to add dextrose when glucose hits 250 because you do not want them to go into hypoglycemia. So a quick mnemonic I use is DKA, don't kill with acidosis. Sounds right? You're going for D, dehydration. You need to give them fluids. K, ketones. You need to give them insulin. A, assess. You need to assess potassium and replace as needed. NCLEX love asking, what do you give first? The answer is IV fluids. You give IV fluids first before you give insulin. Okay. HHS is hypoosmolar hyperglycemic state. These are type 2 diabetes, usually older adults. There's key difference from DKA. There's difference from DKA, diabetic ketoacidosis, and HHS, hypoosmolar hyperglycemic state. Blood glucose is crazy high because they are above 600, sometimes 1,000. They don't have ketones. They don't have acidosis. They only have some insulin, just not enough. They are severely dehydrated and they have altered level of consciousness. The treatment is also the same as DKA, but they need tons more fluid because they are severely dehydrated. NCLEX tip: if glucose is 600, above 600 with no ketones, think HHS, not DKA, because DKA comes with ketones, it comes with fruity bread. They don't have that in HHS. Their blood glucose is high, they don't have ketones, they don't have acidosis, they're severely dehydrated, and they are altered level of consciousness. Okay, now hypoglycemia, the quick killer. Blood glucose is less than 70. That's hypoglycemia. If their blood glucose is less than 40, that is danger. You need to treat ASAP. The signs is the shakes. The shakes, when I say the shakes, we mean tremors, they're sweating, they're tachycardia is their heart rate is above 100, they're confused, they are easily irritated. Seizures can happen if it's severe, and it can progress to coma. Now, the rule of 15. You want to give 15 grams of fast-acting carbs like apple juice, orange juice, glucose tablets. You want to wait 15 minutes. You want to recheck glucose, and if it's still low, repeat. And that is if they're AO times 4 and they can still talk. They're conscious. If unconscious, you need to give glucagon, IM or sub-Q, not IV. Or you could do D5, depending on how severe, you could do D5, D50 IV in the hospital. Now, you always want to start, best practice, NCLEX, you always want to start non-invasive to invasive. So you want to give least invasive before invasive, and depending on patient condition. Now, Kaplan loved this. Patient on NPH insulin, they skipped lunch, they are now shaky and confused at 3 p.m. They are hypoglycemic from peak insulin without food. This is also where you need to know your insulin, the names, the types, short-acting, regular, fast, long-acting, intermediate. You want to know their duration, you want to know their peak, and you want to know their onset, duration, peak. Now, quick insulin timing. You need to know this peak. Rapid insulin is insulin lispro and insulin aspart. It peaks at 1 to 2 hours. Regular peaks at 2 to 4 hours. NPH is intermediate, and it peaks 4 to 12 hours. You want to watch for afternoon hypoglycemia. And then insulin glargine and determal, that's your long-acting. They do not have peak. They are like a 24-hour thing. Now, practice question. Question 1. Your DKA patient glucose drops to 250. What do you do? Well, you add dextrose to the IV while continue insulin. We treat until acidosis resolve. That is when their pH is above 7.3, their biocarb is above 18. Remember, you need to know your normal range levels for this. And for your pH is 7.35 to 7.45. For your bicarb is 22 to 26. And you want to keep giving them insulin until glucose normalizes. If you stop insulin too early, ketoacidosis continues. Now, you got diabetes? Good. Moving to thyroid. Stay with me. We're going to do this really quick. Thyroid disorders. Thyroid. Think about your body thermostat and metabolism. Hypothyroidism, also known as Hashimoto's. Everything slows down. Hypo slows down. Classic signs: slow weight gain, slow metabolism, bradycardia, hypotension, cold intolerance. They are always freezing, even when it's not. The weather does not call for freezing. constipation, their gut is slow. Like, just think of everything that will make your body slow down. Weight gain, slow metabolism, bradycardia, hypotension, cold intolerance, they're always freezing, constipation, the gut is slowing down, they are fatigued, they're depressed, they have brain fog, dry skin, hair loss, myxedema. Myxedema is when the face is puffy, like facial edema, but not really edema, but more of puffiness. There are labs we want to be watching for. The labs we're expecting is high thyroid stimulating hormone, THS. That's the Pituitary screaming, take more thyroid hormone. And then they have low T3, low T4. That's your thyroxine 3 and thyroxine 4. Your treatment for this is levothyroxine, also known as levothyroxine is the generic name. Brand name is Thyroid. But just know levothyroxine. They're always going to ask you the generic name. Patient teaching for levothyroxine. You want to take in the morning on empty stomach. You want to take 1 hour before food or 2 hours after food. You do not want to take with calcium ion on antacid because it blocks absorption. They want to report signs of hyperthyroid. That means the medication the dose is too high. Now, Kaplan loves, take levothyroxine with breakfast. Wrong. You need to take it on empty stomach. Now, we have hypothyroidism. This is also known as grave disease. Remember, hypothyroidism is Hashimoto. Hyperthyroidism is grave disease. Everything speeds up. Opposite of hypo. Now, classic sign, fast. Their weight loss despite eating a lot. Their tachycardia, their hypotension, their palpitation. They have intolerance. Their heat intolerance. They're always hot and sweating. Diarrhea. Their gut is like really fast. Nervousness, irritability, tremors, expoliptomas. That is also another word for bulging eyes. Expoliptomas. Bulging eyes is grave specific, and they have goiter, that's enlarged thyroid. The labs you're expecting is low THS. That's the pituitary gland is saying, oh, we have enough. And they have high T3 and high T4. Treatment is metomazole or PTU. It blocks thyroid hormone production. They are also on propranolol, which is it controls cardiac symptoms. Radioactive iodine destroys thyroid tissue, and sometimes they have to do surgery, thyroidectomy. Okay, continue. Post-Thyroidectomy complications include hemorrhage, airway obstruction, because that's why you need to have your suction and tracheostomy kits ready post surgery. Laryngeal nerve damage, hoarseness, weak voice. They are always hypoglycemia from accidental parathyroid removal. You want to watch for hypocalcemia signs. That's the Chvostek sign. That's tap cheek, facial twitching. The Trousseau sign, that's inflates BP cough, hand spasm. Numbness, tingling around the mouth, tectony, seizure if severe. You always want to have calcium gluconate at bedside. Now, quick tip. Thyroid storm is life-threatening hyperthyroid crisis. They have fever, high fever above 104 degrees Fahrenheit. They have severe tachycardia. They have confusion. They have agitation. The treatment is PTU, propranolol, cooling measures, and hydrocortisone. And then myxedema, coma, that's the life-threatening hypothyroid crisis. So thyroid storm is life-threatening hyperthyroid crisis, and then myxedema, coma is life-threatening hypothyroid crisis, where they have severe hypotension, bradycardia, hypothermia, decreased level of consciousness. Treatment is IV levothyroxine. Warming, you want to warm them up and you want to give supportive care. Practice question. Patient post-thyroidectomy has positive thyroxine sign. What do you give? You want to give calcium gluconate IV, because thyroxine sign means they're hypocalcemia from parathyroid damage during surgery. Amen, somebody? Amen. Let's go. We have adrenal disorders. Adrenal glands, this makes cortisol and aldosterone. Two main disorder, opposite presentation. So for adrenal disorders, we have Addison disease. They don't have enough cortisol or aldosterone. Now think Addison. You add everything that is low. Make sense? Classic sign or presentation is hypotension. They are especially orthostatic. That's when they want to get up and sit down. Hyponatremia, low sodium. Hyperkalemia, high potassium. So we need to know that aldosterone is the hormone that helps with the excretion of potassium and retaining of sodium. So when they have Addison, it causes hyponatremia. They're losing sodium, and hyperkalemia because it's not helping regulate potassium excretion. Whew. Hypoglycemia because there's no cortisol. Remember, cortisol is the stress hormone. So when there's no cortisol, there hypoglycemia. When there is cortisol, it increases hyperglycemia. Bronze skin, they have hyperpigmentation, which is a classic finding. Bronze skin, weakness, fatigue, weight loss. Let me say the classic sign again: hypotension, hypernatremia, hyperkalemia, hypoglycemia, bronze skin, weakness, fatigue, and weight loss. And you have the GI symptoms: nausea, vomiting, diarrhea. Now, Addison crisis is life-threatening. They are severe hypotension, shock, severe hypoglycemia, hyperkalemia, cardiac arrest risk. Our treatment is IV hydrocortisone start, IV fluids and dextrose, treat hyperkalemia. For stable Addison patients, you want to take hydrocortisone daily. You never skip it. You want to increase dose during stress, like example of what will cause stress to be illness, surgery, trauma. You want to wear medical alert bracelets, and you want to take for your diet, you want to have high sodium, low potassium diet. Now, Cushing syndrome, so much cortisol, highly stressed, Cushing's appearance. So, how do I explain this? Moon face, round puffy face, buffalo hump, fat part on upper back, central obesity. That's when they say central obesity, their abdomen, they'll have stretch like purple stripe on abdomen. They have thin extremities. They could be big in the middle, and then they have like skinny legs and skinny hands. Purple striations, stretch mark on abdomen. Hyperglycemia, the cortisol raises glucose. Hypertension, erotism, that's when they have excess hair growth for women. That's men always have hair growth, that's normal for them. But when it's in women and it's excess, that's erytheism. Easy bruising and poor wound healing. The labs we should expect is high cortisol, hypernatremia, hypokalemia, opposite of Addison, and hyperglycemia. The treatment you want to treat, the cause is either you remove the tumor or you stop thyroid. You stop, no, not thyroid, you stop steroids. Stop steroids, you give them, the meds for them is corticonazole or mitotan, which decreases cortisol. Post-op, after surgery, if they removed it, you want to watch for Addisonian crisis, sudden cortisol drop. Now, important nursing points. Glucocorticoid, that's your prednisone teaching. You never stop abruptly. You must always taper. You want to take in the morning to mimic natural rhythm. You want to take with food to avoid GI upset. You want to report signs of infection because steroids suppresses immune system. And Cushing effects with long-term use. That's their bone is not going to be strong. They're going to have like, they'll more have like bone deformity. Bone is not going to be strong basically because of the steroid blocks. If you know your patho down that route, I promise 20 to 25 minutes. I'm going to try to wrap this up. Patients with Addison disease scheduled for surgery tomorrow. And clear practice question: what do you anticipate? Well, you anticipate increased hydrocortisone doses because stress from surgery requires more cortisol. Without it, they go into additional crisis. Pituitary disorders. Pituitary, the master gland. Two disorders that sound similar but are opposite. SIADH. Okay, let me explain. That is syndrome of inappropriate Addison. Wait. That basically means too much ADH. The kidneys hold on to too much water. When you think SIADH, think soaked. SIADH means syndrome of inappropriate antidiuretic hormone. Yes, I remember it. Okay. It's basically when they have excessive amount of ADH from posterior pituitary gland, which results in water imbalance, causing water intensification, like fluid retention, which is opposite of diabetes insipidus, DI, head injury, lung cancer. The indications are decreased level of consciousness, cerebral edema. Okay, I was going to dip there for a minute. So think SIADH, think soaked. Classic presentation: hyponatremia, that's delusional, that's they have too much water, low urine output, it is dark and concentrated, weight gain, fluid retention. They don't have edema. There's no edema, but they would have weight gain due to fluid retention, but there's no edema like compared to heart failure. Confusion, seizures from low sodium. Now the labs to watch for is your sodium. It's 135 to 145. Sometimes it's always low, 120, 118. So urine specific gravity, you want it to be above 1.030. It's very concentrated. Serum osmolality is low and urine osmolality is high. Treatment is fluid restriction. That's the most important. Hypotonic saline, if severe, that's hypotonic saline is your 3% normal saline, 3%. Yes, 3%. But you want to give it slowly because of risks for central portline melanosis. Patho again. Salt tablets, you also want to give them. dimethyloxine or titovapan. Tovaptan. It blocks ADH. Warning, you need to correct sodium slowly. Don't do it fast. No more than 10 to 12 MEq per liter per 24 hours. Diabetes insipidus, that's DI, there's not enough ADH. Remember, SIADH is symptom of inappropriate antidiuretic hormone. This one, there is for diabetes insipidus, there is not enough antidiuretic hormone. Kidneys dump too much water. Think DI dry. SIADH soaked. Classic presentation is polyuria. That's peeing 4 to 20 liters per day, polydipsia, extreme thirst, hypernatremia, losing water, concentrating sodium, weight loss due to fluid loss, dehydration. Their labs will be sodium will be above 145. Urine specific gravity, it will be dilute and watery, so it will be less than 1.005. Our normal should be 1.015 to 1.030. That's the range. Serum osmolality is high, urine osmolality is low. Treatment is desmopressin, DDAVP, is the synthetic ADH. It also comes like in nasal spray or sub-Q. IV fluids if dehydrated and you want to monitor input and output really closely. Now, let's do a chart. SIADH versus DI quick chart. ADH is too much in SIADH, too little in DI. Urine output is low in SIADH, is high in DI. Urine specific gravity is high in SIADH, that is above 1.030, and it's low in DI, it's less than 1.005. Serum sodium is low in SIADH, serum sodium is high in DI. Think soak for SIADH and think dry for DI. Treatment is to restrict fluid for SIADH, and treatment for DI is to give desmopressin and fluids. Practice question. Patient with head injury has urine output of 500 ml per hour. Dilute urine, sodium 155. What is that diagnosis? Ding, 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 ding. Diabetes insipidus. High output, dilute urine, high sodium. We need to give them desmopressin. Parathyroid quick hit. Parathyroid controls calcium, quick and dirty. Hyperthyroidism, too much parathyroidism. That's they have high calcium, low phosphorus. They have kidney stones, bones, groins, psychiatric overtones. When I say stones, kidney stones, because of too much calcium, low phosphorus, they are bones, they have bone pain, fractures, groins, abdominal pain, constipation, psychiatric confusion, and depression. Treatment is surgery. Remove parathyroid adenoma. Hypothyroidism. There is not enough parathyroid. That means low calcium, high phosphorus. That is where we have the Chvostek sign, the Trousseau sign, the tetany, the seizures, the numbness, the tingling. Our treatment is calcium supplements, vitamin D, calcium gluconate IV for acute or severe. And the mnemonic you want to know is calcium and PTH are friends. They go up and down together. So high PTH, hyper, high calcium, low PTH, low calcium. That's hypo. Now, let's wrap up. Rapid fire interview review the must know mnemonics. DKA, don't kill with acidosis. Hypothyroid, slow everything. Hyperthyroid, fast everything. Addison, bronze skin, low everything. That's low sodium, low glucose, low BP. Cushing, moon face, buffalo hump, high everything. SIADH, soaked, restrict fluid. DI, dry, give desmopressin and fluid. Hyperthyroid, you want to watch for stones, bones, groins, psych overtones. Post-Thyroidectomy is watch calcium, have calcium gluconate ready. If you know this pattern, you can answer 90% of endocrine questions confidently. Whew. Listen, endocrine feels overwhelming because every disorder has opposite presentation. But once you see the patterns, it clicks. You need to be able to know the major stuff so you can see the pattern. You just learned in, I know I said 20 to 25 minutes, but you just learned in 30 minutes what takes hours to study from a textbook. Review this video before your Kaplan or your NCLEX and you'll be ready. Drop a comment. What endocrine disorder confuses you most? Let's help each other. Like this video if it helped. Subscribe for more rapid reviews, and I'll see you in the next one. You got this, future nurse. Now go ace that exam. Go ace that NCLEX. Go ace that exit exam. Bye. See you next time.